Pathology for Physical Therapy Assistant, Part 3, Chapter 4, The Immune System, page 97. The person with AIDS often develops pneumocytitis, pneumonia, PCP, and or other opportunist infections and quickly succumbed. During this period, the PTA's role was primarily that of pain control, energy conservation, and instruction in the use of adaptive equipment to maximize functional ability. Today's prophylactic medications are highly effective in the prevention of PCP and many other opportunistic infections and HIV-associated conditions. Chronic conditions such as cardiovascular disease related to LDS and rheumatologic and musculoskeletal conditions are much more common in those living with HIV. Therefore, PTAs are generally focused on assisting the individual with their management of physical functions related to the chronic disease. From a rehabilitation point of view, HIV is considered a chronic illness on a continuum from being asymptomatic to exhibiting mild to severe symptoms, rather than a terminal illness. The individual with HIV disease may demonstrate clinical manifestations of overlapping pathologic processes and HIV-related physical disabilities that necessitate appropriate rehabilitation. In addition to physical fitness and strength training, PTAs must look at quality of life issues, work simplifications, activities of daily living, ADLs, including community management skills such as access to transportation, socialization opportunities, shopping, banking, and ability to negotiate healthcare and insurance systems, and participate in church, synagogues, or other spiritual network. Home programs must be simple and easy incorporated into ADLs. Often individuals with AIDS are overwhelmed by the disease process, the complicated treatment, the multiple healthcare appointments, and the scheduling to manage all of these tasks. Adding an exercise program may result in frustration and non-compliance unless the person can see a clear benefit and way to manage yet another aspect of the treatment program. The PTA must be prepared for seizures, which may occur as a result of nervous system involvement, sometimes for the first time during a therapy session. Cognitive deficits in attention, concentration, and memory necessitates consistency, structure, and environmental cures to minimize confusion. Quickly progressive peripheral neuropathy is one of the most common types of pain experienced by people with HIV, sometimes as a result of drug use to treat HIV or possibly related to HIV-induced immune complexes. Conventional transcutaneous electrical nerve stimulation may exacerbate peripheral pain in HIV-related peripheral neuropathies and should not be used. Joint and soft tissue mobilization, stretching, gait balance training, desensitization techniques can also be very effective. The alternate use of microcurrent acupuncture has been reported to reduce pain, improvement of functional status, and increased perceived strength. Discussion of the possible mechanisms for these effects is available. The body may begin to draw from its own fat stores, affecting the myelin sheaths of nerves, which are protected by fat, without proper nutrition. Therapy involving balance training, extremity strengthening, and motor skills, although extremely important, may be limited in benefit. Diminished sensory information associated with peripheral neuropathies of the lower extremities makes balance and gait control more difficult. Clients with AIDS may have balance deficits at lower movement speeds compared with healthy adults. Motor slowness is associated with both neuropathy and myopathy. Formulating a rehabilitation approach must be based on the underlying neurophysiologic deficits present. Other guidelines for management of lower extremity complications and balance and postural derangements associated with distal systemic polyneuropathy are available. For individuals with painful myopathy in large muscle groups, progressive resistance training with weights or elastic bands or tubing to strengthen specific muscles may be beneficial. Muscle spasms accompanying myopathy may respond well to gentle but consistent stretching exercises. Post-exercise soreness is common in AIDS patients experiencing muscle pain. A longer rest period between exercises may be necessary. Improper body mechanics, poor postural alignment and postural instability, balance and gait problems, and other biomechanical changes may occur in the person who has developed muscle weakness and fatigue from progression of the disease process. Malnutrition or wasting syndrome, again, postural awareness, stretching, and strengthening of specific muscles and attention to nutrition may be a part of the treatment plan. In cardiopulmonary complications, see Table 4.1, in advanced stages of AIDS contribute to morbidity and mortality. Oxygen transport mechanisms can be adversely affected. Muscle and joint mobilization techniques and breathing exercises are essential for a person who has been immobilized for any length of time as a result of respiratory or other disease involvement. The rib cage is one area where normal respiratory and accessory movements are essential for adequate lung ventilation, energy conservation, correct posture, and balanced reactions. Exercise and HIV/AIDS. Unlike other infections, HIV directly affects the immune system. Exercise has clinically significant effects on the immune system responsiveness. Therefore, potential exists to alter the natural history of HIV infection in beneficial manner through the use of exercise. See discussion in the section on exercise immunity in this chapter. A growing number of studies are now addressing the issue of relationship between exercise and HIV infection. The results are summarized here in box 4.3. Early stage HIV disease. Exercise is considered safe for people with HIV and an important way to increase the CD4 cells at early stages of the disease, possibly delaying symptoms while increasing muscle strength and size. During asymptomatic stages of HIV disease, metabolic parameters are within normal limits, with no limitation placed on the individuals. Individuals with asymptomatic HIV disease should be encouraged to exercise regularly, including both aerobic and resistance exercise components. The effect of HIV and its treatment with protease inhibitors on exercise and activity tolerance has been reported. Physical activity intolerance resulting in functional limitations may be caused by diminished aerobic capacity, decreased peak VO2, far below that occurring as a result of physiologic deconditioning alone. Individuals also who receive HAART may have a reduced ability to extract and use oxygen from the muscle during exercise, limiting their ability to increase the intensity of activity. Systematic and advanced stages of HIV disease. During systematic and advanced stages of HIV disease, functional capacity is reduced, requiring more individual exercise, prescription, and lower intensities. Neurologic dysfunctions and deconditioning are common. Regular physical activity and exercise are just as important in this group, but are more difficult and symptoms limited. Among people with HIV who have known cardiovascular disease, pulmonary limitations, or muscle dysfunction, exercise prescriptions should address impairments and limitations. Collaboration with physician to determine any contradictions for exercise is advised. Strenuous exercise training is not recommended. Aerobic exercise at moderate levels of intensity is suggested with medical clearance. Consistent or interval aerobic exercise for at least 20 minutes at least 3 times per week for 4 weeks may lead to improved cardiopulmonary fitness and improve physiologic status. I can't believe it took me 9 minutes to read that one page. Oh my gosh. 9 minutes. With an accompanying maintenance of immunologic function, supervised aerobic exercise training safely decreases fatigue, weight, body mass index, fat, and central fat in HIV-1 infected individuals. It may not affect dyspnea. Clients with advanced disease may be at greater risk for exercise-related injuries caused by chronic myopathy and neuropathy. Tissue changes. Recovery periods after exercise may be prolonged compared with asymptomatic or early-stage individual. Response to exercise should be carefully monitored. Chronic fatigue and immune dysfunction syndrome overview. Chronic fatigue and immune dysfunction syndrome, chronic fatigue syndrome, chronic Epstein-Barr virus, myalgic encephalomyelitis, neuromyasthenia, and the yuppie flu all denote a highly publicized but not new illness. The name chronic fatigue syndrome, CFS, indicates that this illness is not a single disease but the result of a combination of factors and is actually a subsequent of chronic fatigue, a border category defined and is actually a subset of chronic fatigue. I backtrack. A border category defined as unexplained fatigue or greater than or equal to 6 months duration. This distinction is made to facilitate epidemiologic studies of the population with prolonged fatigue and chronic fatigue. Incidence and risk factors. 2 U.S. community-based CFF studies found prevalence among adults of 0.23% and 0.42%. The rates were higher in women, members of minority groups, and people with low educational attainment and occupational status. Alani. People of every age, gender, ethnicity, and socioeconomic group can have CFS. Demographic data shows that in most studies, 75% of more people with CSF are female. The mean age at the onset of CFF is 29 to 35. The mean illness duration ranges from 3 years to 9 years. Although CFS is much less common in children than in adults, children can develop the illness particularly during the teen years. Etiologic factors and pathogenesis. Many somatic and psychosocial hypotheses on the etiology of CFS have been explored. Etiologic factors and pathogenesis. Many somatic and psychosocial hypotheses on etiology or CSF has been explored. Explanations of CFS were sought in viral infections, immune dysfunctions, neuroendocrine responses, dysfunction of the CSS, muscle structure, exercise capacity, sleep pattern, genetic constitution, personality, and neuropsychologic processes. Abnormalities of the neuroendocrine system and CNS alone are not sufficient to explain the symptoms of CFS. More complex interactions between regulating symptoms are assumed to be at work and seem to involve the CNS, the immune system, and the hormonal regulation system. The etiology and pathogenesis are generally believed to be multifactorial. Personality and lifestyle are presumed to influence vulnerability of CFS. Personality characteristics of neuroticism and introversion have been reported at risk factors for the disorder. Inactivity in childhood and inactivity after infection mononucleosis have been found to increase the risk of CFS in adults. Also, acute physical or psychological stress might trigger the onset of CFS. 3/4 of the individuals with the disorder have reported an infection such as a cold, flu-like illness or infection, mononucleosis as the trigger, and his rates of chronic fatigue after Ch.4 and Lyme disease have been found. Finally, serious life events such as the loss of a loved one or a job and other stressful situations have been found to precipitate the disorder. Alani, what you doing? Oh my goodness. Sorry, I had to stop her from eating wrapping paper. Lost where I was. I'm going to start, I think it was, I left off at clinical manifestations. The most commonly reported CFS symptoms at illness onset are sore throat, fever, muscle pain, and muscle weakness. As the illness progresses, muscle pain and forgetfulness increase along with prolonged, lasting more than 6 months, and often overwhelming fatigue that is exacerbated by minimal physical activity. Neutrally mediated hypotension, NMH, caused by disturbances in the autonomic regulation of blood pressure and pulse, is common in people with CFS. The condition is characterized by lightheadedness, visual dimming, or slow response of verbal stimuli. Many people with M and H experience lightheadedness or worsening fatigue as they stand for prolonged periods or when in warm places, hot showers, sauna, indoor pool environment. The severity of CFS varies from person to person, with some people able to maintain fairly active lives. By definition, however, CFS significantly limits work, school, and family activities. Symptoms vary from person to person in number, type, and severity, but all individuals with CFS are functionally impaired to some degree. CDC studies show that CFS can be as debilitating as multiple sclerosis, MS, lupus, rheumatoid arthritis, heart disease, end-stage renal disease, chronic obstructive pulmonary disease, and similar chronic conditions. CFS often follows a clinical course alternating between periods of illness and relative well-being. Some people experience partial or complete remission of symptoms during the course of the illness, but symptoms often reoccur. This pattern of remission and relapse makes CFS especially hard for clients and their health care professionals to manage. People who are in remission may be tempted to overdo activities when they are feeling better, which can exacerbate symptoms and fatigue and cause a relapse. In fact, post-exertional malaise is a hallmark of the illness. Treatment, because there is no known cure for CFS, treatment is aimed. Alani, shh. Lifestyle changes. Wait, I forgot where it was. Treatment, because there is no cure for CSF, treatment is aimed at symptom relief and improved function. A combination of drugs and non-drug therapies is usually recommended. Lifestyle changes include prevention of overexertion, reduced stress, dietary restrictions, gentle stretching. Nutritional supplementation are frequently recommended in addition to drug therapies used to treat sleep disturbances, pain, and other specific symptoms. Carefully supervised physical therapy may also be a part of treatment for CFS, but symptoms can be exacerbated by overly ambitious physical activity. A very moderate approach to exercise and activity management is recommended to avoid overactivity and to prevent deconditioning. Symptomatic reviews have investigated the effectiveness of several CFS treatments, and cognitive behavior therapy and graded exercise therapy are the only interventions found to be beneficial. 4.4, special implications for PTAs. Chronic fatigue syndrome. The client with chronic fatigue syndrome, CFS, is treated according to guidelines and protocols for autoimmune disorders such as fibromyalgia. Pacing, energy conservation, stress management, and balanced life activities are extremely helpful in preventing worsening of fatigue and maintaining an even flow of energy from day to day. Support groups may be beneficial in providing emotional and psychological support and in helping the individual keep with the latest research results and progress in medical interventions. Exercise and chronic fatigue syndrome. Carefully controlled and graded exercise is the center of effective intervention for CFS. Many affected individuals fear a relapse and avoid physical activity and exercise. But deconditioning and muscle atrophy increase fatigue and make other symptoms even worse. The PTA can be very instrumental in providing a prescriptive program of regular moderate exercise to avoid deconditioning while advising against overexertion during periods of remission. People with CFS are unable to sustain physical activity or exercise during acute onset or flare-ups. Beginning with low-level intermediate physical activity throughout the day to accumulate 30 minutes of exercise has been shown to be effective with exacerbating symptoms. People with CFS may also have significantly reduced exercise capacity. Always assess for conditioning before initiating even a simple exercise program with anyone who has had CFS longer than 6 months. Athletes and sport participants may require special help to develop a progressive exercise regimen. Impairments of peak aerobic power and muscle strength may occur with self-imposed or physician-imposed inactivity. The PTA must observe for altered breathing patterns, components of poor posture, and insufficient or biomechanically faulty movement patterns contributing to pain. Addressing these areas is an important part of the rehabilitation process. Stretching, strengthening, and cardiovascular training are essential aspects of therapy. Like people with fibromyalgia, girl, get out from over there. I can't remember where it was, so I'm just going to stretching, strengthening, and cardiovascular training are essential aspects of therapy. Like people with fibromyalgia, those diagnosed with CFS must progress slowly and avoid overexertion because they often do not have the internal mechanisms to alert them to stop an activity. Soft tissue and joint mobilization combined with stretching are important components of intervention, especially in the presence of postural components of faulty mechanics. Prolonged inactivity rest is a poorly supported position for long periods, and assuming postures dictated by pain can contribute to muscle shortening. Over time, some individuals can be progressed to graded aerobic exercise therapy. Continuous exercise must be started at a short duration, appropriate to the client's baseline ability. A more specific description of how to deliver graded exercise therapy to the people with CFS is available. This has been shown to be significantly more effective than just stretching and relaxing exercises. Monitoring vital signs. Assessment of vital signs in adults with CFS may demonstrate very large fluctuations in pulse rate, blood pressure that are not consistent with the person's position or movement, whereas the blood pressure and the pulse rate normally show a slight increase as a physiologic response to a change in position from sitting to standing. Orthostatic hypotension is marked in the CFS population. Vital signs may stay in the same or even decrease, resulting in vital signs may stay the same or decrease and resulting in dizziness, lightheadedness, or loss of balance. The symptoms may result in decreased self-confidence and the ability to pursue activities. During the initiation of exercise program, it is advised to monitor blood pressure rate, perceived exertion, heart rate, and respiratory rate for any signs of physiologic distress, although the rate of the perceived exertion may not change during the exercise session. The individual may perceive fatigue as worse after initiating exercise. However, if this increase in fatigue does not exceed 1 unit on a scale from 1 to 10 from the baseline level established before, exercise symptoms exacerbate after exercise can be potentially avoided. Alrighty. Next page. Page 100. Hypersensitivity disorders. Alright, I'm just going to finish this chapter up once she goes to sleep.